So now we're talking, so we briefly talk about the sort of blood cancers and the topic, the first topic of discussion, then followed by the means of diagnosis and management of and classification or stratification of these blood cancers. And now we're going to discuss about the management and treatment of these cancers, of course, followed by the role of bone marrow transplantation. Traditionally, these blood cancers we're treating with chemotherapy agents, but it's very interesting because there are other options at this point that have been that have changed the scope of practice in terms of blood cancer treatment. The first group of medications are called immunotherapy, which is basically sort of agents that target specific receptors in cancers. They're being used over the, believe it or not, over the last 15 to 20 years. They help in terms of, in combination with chemotherapy agents, they work very nicely. And as I said, again, the goal of all these cancers and the treatment of all these blood cancers is to cure patients. So the intent is to cure patients when we start treating them. So besides chemotherapy, which of course has some side effects, and the common side effects of chemotherapy include nausea, vomiting, diarrhea, persistent inflammation with the whole body, and so forth, there are other potential side effects as well that, of course, we manage in patients. But in terms of immunotherapy, there could be also some complications, such as some inflammatory reactions in different parts of the body and so forth, but it's much less compared to the regular or conventional chemotherapy. Traditionally, what we use is we use immunotherapy in combination with chemotherapy for many lymphomas, chemotherapy as such with some of the immunotherapies in the form of monoclonal antibodies for acute leukemias. We use basically other agents such as targeted therapy for chronic leukemias, and we use the conventional chemotherapy for myelofibrosis and also for myelodysplastic syndrome. Multiple myeloma is a very unique case in which we don't usually use the plain chemotherapy. We tend to use more sort of, if you will, targeted therapy and immunotherapy. And patients do very well and respond very well. Of course, there is a subset of patients with multiple myeloma who are higher risk, who may develop more complications, but traditionally these patients respond very well to therapy. So the third line or the third group of interventions include the presence of targeted therapy. Targeted therapies are, if you will, the sort of the new kids on the block in terms of in oncology. Help because targeted specific markers in blood cancers are very unique because they specifically attack certain portions of the cancer. And they're very unique in the sense that in terms of side effects, it's very tolerable, highly tolerable. That doesn't mean that it's a very easy sort of group of drugs to use, but it's of course less. This side effect profile is much less, or the toxicities are much less compared to the regular conventional chemotherapy. Within this immunotherapy, if you will, there is always the option of bone marrow transplant. That can be done from the own patient or from yourself, which is called autologous bone marrow transplantation. Usually that's used for in the cases of multiple myeloma, as we said in the second segment, and also in the case of certain lymphomas, in which we, after treating and achieving what we call a complete remission, patients may go into a bone marrow transplantation sort of procedure to consolidate their disease and to just kind of make sure that the patients are well controlled. So within the immunotherapies as well, we have the allogeneic or donor bone marrow transplant. Very efficient and very curative, but of course with significant side effects. In this case, for bone marrow transplantation, allogeneic or donor bone marrow transplantation, we look for donors. We prefer, of course, siblings, followed by unrelated, much unrelated donors, followed by haplodonors, meaning either children or parents, or up to a certain extent also second-degree relatives, followed by mismatch-related donors and mismatch unrelated donors. What I'm trying to tell you here is that For an allogeneic or a donor bone marrow transplant, the first condition is, of course, we definitely need to have a donor just before we proceed with any sort of further intervention. This is a part of the immunotherapy armamentarium that we have at this point, highly effective because this, of course, can cure many conditions. But at the same time, the side effect profile is very toxic. So the side effect profile is present. There are significant side effects that besides the regular nausea, vomiting, and diarrhea, there are other side effects that could be sometimes very complex. And as such, we need to always consider this option, but also always balancing the potential side effect profile that may develop from this intervention. Then besides that, targeted therapy, immunotherapy, chemotherapy, in certain occasions, we may use radiation therapy, especially for early cases when we have certain kind of lymphomas. And at that time, whenever it's an early kind of early lymphoma with an early stage, we can use radiation therapy and we can potentially cure patients. That could be another potential approach that we use. In our populations, what usually happens is that we use a combination of factors or a combination of different strategies. So we start using chemotherapy followed by, or in combination with immunotherapy, followed by an autologous transplant, or perhaps followed by a donor or allogeneic bone marrow transplant, followed by perhaps any other kind of targeted therapies. One group of one intervention, and it's been developed over the recent years, over the last 2 or 3 years, is called a CAR T-cell therapy, and also something called the BiTE therapies, which is basically the sort of a technology of manipulation of T cells from their own patient, from the patient, to look at and teach the T cells to basically attack certain receptors of the cancer, of the tumors. This is a new technology, very innovative, is basically revolutionized the field of hematologic malignancies. But it's very important to mention this because in the next few years, we're going to have more and more clinical trials looking into how to use and how to incorporate this CAR T-cell therapy in different types of blood cancers. So far, CAR T-cell therapy has been approved for certain cases of acute lymphocytic leukemia, and also has been approved for certain cases of lymphomas, especially the high-grade lymphomas, and primary medicinal B-cell lymphomas, and also certain indolent lymphomas that transform into more aggressive lymphomas. So to recap, so there are many ways that we can tackle these blood cancers. Usually it's a combination of therapy. Usually is chemotherapy, immunotherapy, followed by autologous or allogeneic bone marrow transplant. The presence of CAR T-cell therapy is there, and also the potential use of targeted therapies that make a big difference or a big impact in terms of the treatment of blood cancers. Again, the intent is to cure, and in certain occasions, of course, we may face a case of refractory relapse disease, but for which we have other interventions like the ones that I mentioned, bone marrow transplantation from the same patient or from a donor, or the presence of CAR T-cell therapy.